Right, so all right, so a very good evening, everyone. Right, so I am audible to everyone. Yes, am I audible to everyone? All right. So I welcome you all to this particular YouTube session. So I'm myself, Dr. Rajesh Guba. I'm the General Medicine Educator on Arise Medical Academy platform. So in this session, I will be discussing the image-based questions on the Pulmonology Part 3. So already we have done two series or two sessions on the image-based questions on pulmonology. And pulmonology being a very important topic, right? More and more image-based questions can be asked for you. And the other important point is every day at 10:30, I'm live on the same platform for discussing image-based questions of various topics in the general medicine. So try to utilize this particular platform, which is available for you for free, and see that this particular images, whichever I am discussing, will be useful for your upcoming FMGE exam. And before this particular pulmonology, I have discussed the two sessions on the endocrinology. So please utilize that particular image-based questions which I have discussed on endocrinology, and try to see that you will not miss any particular single question in your exam related to images of endocrinology. All right. Now, let us start with the first question today. And if you want these particular images, right, if you want the PDF of this particular images, you can join my Telegram channel, that is Rajesh Guba or Medicine Made Easy by Dr. Rajesh Guba. That is my Telegram channel name, Medicine Made Easy by Dr. Rajesh Guba. So the PDFs of this particular topics, whichever I am doing, will be available for you on my Telegram channel. Okay, right. Let us start with the first question. Yes, Samuel Alamatu, good evening. Right. Yes, you see this question. Which of the following is not the feature of this disorder shown you in the image? Yellow nail syndrome, pulmonary manifestations, lower limb lymphedema, cardiomyopathy. Which of the following is not the feature of this particular disorder? Yes, can anyone make an attempt? Very good, Vijay Bhargava. Excellent. So Vijay Bhargava has answered first. So what is this particular condition? This particular clinical condition, whichever is shown to you in the image, is suggestive of yellow nail syndrome. Right? It is suggestive of yellow nail syndrome. Now, in these patients with the yellow nail syndrome, you have a triad. Right? You have a triad in these patients with the yellow nail syndrome. Now, what is that particular triad in these patients with the yellow nail syndrome? The triad includes the following. Number 1, yellow nail discoloration. Number 2, pulmonary manifestations. That is the one which is characterized by chronic cough, bronchiectasis, and pleural effusion. And the third one is the presence of lower limb edema. Third one is the presence of lower limb edema. These three are the manifestations what you will see in patients with the yellow nail syndrome. And along with this particular triad, in patients with the yellow nail syndrome, there will be also presence of the chronic sinusitis. There will be also presence of chronic sinusitis. So in patients with this yellow nail syndrome, you don't have this feature of the cardiomyopathy. Now, what will be the treatment of this yellow nail syndrome? And what are those pulmonary manifestations? Pulmonary manifestations will be like chronic cough, bronchiectasis. So you have to treat symptomatically, right? Next, you take this yellow nail discoloration. How can you see that this yellow nail discoloration will get disappeared? This yellow nail discoloration can disappear whenever you supplement the individual with vitamin E. Right? Vitamin E has to be supplemented. So whenever you give this vitamin E, then this particular yellow nail discoloration will get disappear. So this is a triad. This is an image that can be shown you as a triad itself. What is this? This is your lymphedema, right? And this is your yellow nails. Okay, and this is your pleural effusion. So the pulmonary manifestation can be in the form of the pleural effusion also, right? The pulmonary manifestations can be in the form of pleural effusion also. So please remember, yellow nail syndrome is characterized by a triad, that is lymphedema, yellow nails, and the pulmonary manifestations. Pulmonary manifestations can be in the form of chronic cough, bronchiectasis, and pleural effusion. And you need to do a symptomatic treatment. But for controlling this particular nail changes, what we give is we give vitamin E, right? So that was the question related to yellow nail syndrome, which is characterized by a triad of lymphedema, yellow nail discoloration, and the pulmonary manifestations. And they also have association of chronic bronchitis. They also have association of chronic bronchitis. Right, very good, Shashi Bhushan. So in case of pleural effusion, you have the costophrenic angle blunting. There will be blunting of the costophrenic angle, right? You are true. Next. Now, yes, this is another very important and very interesting question as well. Which of the following will not cause this condition? Iatrogenic, Clostridium perfringens, thoracic trauma, Klebsiella. Which of the following will not cause this condition? Yeah, any one of you, please. First of all, you should be able to tell me the diagnosis. What is the diagnosis? Shashi Bhushan, that is what I said, right? Chronic sinusitis only I said. Did I mention any other thing? Right. First of all, please tell me the diagnosis. Right. So Samuel Alamoto and as well as Mohammad Umar has answered. So the answer is the Klebsiella. The answer is Klebsiella. Now, what is the diagnosis? The diagnosis is hydropneumothorax. Right? The diagnosis is hydropneumothorax. Now, you should know what is hydropneumothorax. See, hydropneumothorax, it is the clinical condition which is characterized by accumulation of air, right? So this is your air, and as well as the fluid in the pleural space. Accumulation of air and as well as fluid in the pleural space. That is what is called as right. That is what is called as the hydropneumothorax. Yes, Shainavaz. So why your questions doesn't come from the notes? Let me tell you, Srinivas, whatever the content what I am teaching you in the routine 6 to 9 classes or 5 to 8 classes, I'm trying to teach you the basic theory part. But general medicine being a very vast subject cannot be discussed just in 100 hours or 150 hours. The entire general medicine, it takes nearly around 250 to 300 hours. That vast is your general medicine. And the content which I am unable to discuss in your regular classes, which I am taking 5 to 8 or 6 to 9, those topics, I mean, that content which I am unable to take, I am trying to discuss in this image-based questions. So from this now, what you should understand, the theory classes which I am taking is also important, and image-based questions, whichever I am taking, is also very important for you, right? Yes, Srinivas, did you understand the point now? Okay. Now, so this is your hydropneumothorax. Hydropneumothorax, it is the accumulation of air plus fluid in the pleural space. That is what is called as the hydropneumothorax. And what are the causes for hydropneumothorax? Hydropneumothorax, the etiology include iatrogenic causes. What is iatrogenic? Like for example, the individual is having the pleural effusion and you have tried to do a pleurisynthesis, but accidentally you have injected the air into the pleural space. That is called as the iatrogenic cause for hydropneumothorax. Now, what is Clostridium perfringens? Clostridium perfringens can also cause this hydropneumothorax. Clostridium perfringens, it is a gas forming organism, right? One is Clostridium perfringens can cause this hydropneumothorax, and as well as even Streptococcus can also cause this hydropneumothorax. And next, thoracic trauma. So whenever there is any trauma, if the air has entered into pleural space along with the fluid, then the individual may land up in hydropneumothorax. But remember, Klebsiella will not cause hydropneumothorax. If at all, if Klebsiella causes, the Klebsiella will cause exudative type of pleural effusion. Klebsiella will cause exudative type of the pleural effusion. But Klebsiella will not cause this hydropneumothorax. Okay, so please remember this very, very important point. So what is this chest X-ray suggestive of? This chest X-ray is suggestive of hydropneumothorax. Yeah, very good, Raja. This Klebsiella will also cause lobar pneumonia. And Klebsiella can also cause exudative type of pleural effusion. But Klebsiella will not cause the hydropneumothorax. Klebsiella will not cause the hydropneumothorax. Okay, that's a very important point that you need to remember. Now, how to identify this hydropneumothorax? Right? Yes, Shashibhushan is asking about the chest X-ray picture in patients with the hydropneumothorax. Let me tell you. In case of hydropneumothorax, you have a presence of a horizontal line. You have a presence of a horizontal line. That is what is called as the hydropneumothorax. And what is that horizontal line between? This horizontal line, it is present in between the air and fluid. That means the fluid, whatever is there, you have that horizontal fluid level. You have that horizontal fluid level. That is what you will see in patients with the hydropneumothorax, right? So I'll repeat all the points again. Hydropneumothorax, it is the condition characterized by accumulation of air and fluid. And you will have the air fluid level and the fluid will be horizontal in the pleural space along with the air. And the etiology for the hydropneumothorax include iatrogenic, Clostridium perfringens, and then thoracic trauma. Klebsiella will not cause this particular hydropneumothorax. That is about your hydropneumothorax. And how do you treat? You need to treat the underlying etiology. You need to treat the underlying etiology. Okay. And if the individual is having very severe dyspnea, then you have to do a wide bore needle puncture of the pleura. Or you have to put the patient on ICD, that is intercostal drain. You have to put the patient on intercostal drain. So that is about the hydropneumothorax. All right. Next. Now, yes, Shashibhushan. you will not have that Ellis S-shaped curve in hydropneumothorax. Ellis S-shaped curve is seen only in patients with the pleural effusion, but not in patients with the hydropneumothorax. Right? Yes, Shashibhushan, is that clear? Right. Now, can anyone identify this X-ray? Can anyone identify this particular X-ray? What is the diagnosis of this X-ray? And what are the findings you are observing in this particular chest X-ray? Right. So, no. Nirbhay Kumar, it is not COPD. Very good. Very good. So, Samuel Alamatu has answered this. So, this is a case of right-sided pneumothorax. Right. This is a case of right-sided pneumothorax. Now, what all you are having in the chest X-ray of this patient, I will tell you one by one. You see, there is a collapsed lung. This is a collapsed lung. Okay. Whatever, I have just put a tick mark, that is a collapsed right lobe of the lung. Right lung, not right lobe, right lung. Now, why is this particular collapse? That is because of pneumothorax. Right? That is because of pneumothorax. That is because of pneumothorax, you have the presence of the collapsed lung. Now, what is that you are observing there? Right? You are observing absent bronchovascular markings. Now, how will the bronchovascular markings appear? Right? So these are your bronchovascular markings. The white lines, whatever you're observing here, these are the bronchovascular markings. And you will have that bronchovascular markings only if you have the presence of a lung parenchyma. But here, there is no lung at all. Lung is completely collapsed. When the lung is completely collapsed, there will be absence of the bronchovascular markings. That is the second point. And the third finding in this chest X-ray, whatever you are observing is, whichever side the pneumothorax is there, opposite side the mediastinum is shifted. Right? Whichever side pneumothorax is there, opposite side mediastinum is shifted. Right? You see this. Trachea, it is pushed to the opposite side. Right? Trachea, it is pushed to the opposite side. So that is about your pneumothorax. So in pneumothorax, you have the presence of collapsed lung. You have absent bronchovascular markings. And third, the mediastinum is being shifted to opposite side. You can see this. The trachea, right? It is curved like this. Trachea is curved like this. Why? Because the pneumothorax, air in the pleural space, will push the trachea to the opposite side. Right? Will push the trachea to the opposite side. That is what you will see in patients with the pneumothorax. Okay? Right. So the X-ray what I have shown you before this was hydropneumothorax. And this particular X-ray is pneumothorax. Okay? Right. Now we will move on to the next question. Yes, this is another very interesting question, and let me see how many of you can answer. Which of the, yeah, very good, Raja. There will be also hyperlucent lung field. That means there is air in the pleural space that will give you a black color. Hyperlucent lung field. Okay. Yeah. Which of the following is not the causative factor for this particular disorder which is shown to you? So what is the image which is given to you? It is a two-dimensional echocardiographic image which is given to you. Now, you have a abnormality in that two-dimensional echocardiography. That abnormality is suggestive of an underlying disorder. Which of the following is not the causative factor for this disorder? No, I did not get the correct answer from, yeah, Divya Chandra has answered. Divya Chandra, Rizwana, right? So the answer is the progesterone therapy. What is the diagnosis? Very good, Samuel Alamatu. So the diagnosis is pulmonary embolism. Diagnosis is pulmonary embolism. Right? Diagnosis is pulmonary embolism. Very good, Samuel Alamatu. And what is the sign shown to you here? It is McConnell sign. The sign which is shown to you is the McConnell sign. Right? So this McConnell sign, where do you observe? You will see this in patients with the pulmonary embolism. Now, the next immediate question is, sir, what is McConnell sign? The next immediate question is, sir, what is McConnell sign seen in pulmonary embolism? McConnell sign is nothing but the pathology or the problem in the right ventricle. The lateral wall of the right ventricle, right? The lateral wall of the right ventricle does not contract. Right? Lateral wall of the right ventricle, there will be no contraction. But there will be contraction of the only apex. Right? There will be, the apex will contract. Right? Apex will contract. That is what is called as the McConnell sign. That is what is called as the McConnell sign. Contraction of the apex, but lateral wall of the right ventricle will not contract. That is what is called as the McConnell sign, seen in patients with the pulmonary embolism. Now, going back to the question. Pulmonary embolism is seen in protein C, protein S deficiency, and antithrombin 3 deficiency. Right? Pulmonary embolism is seen in protein C deficiency, protein S deficiency, and antithrombin 3 deficiency. Right? Next, malignancy, remember, it is a hypercoagulable state. Malignancy, it is a hypercoagulable state. So even in malignancy also, you can have the development of the pulmonary embolism. Next, even in obesity is also a risk factor for the development of pulmonary embolism. So even in obesity, you can have this particular McConnell sign. Okay. And progesterone therapy is not a hypercoagulable state. Right? Very good, Rajkumar. It is high dose estrogen therapy. Right? High dose estrogen therapy. That is the hypercoagulable state. High dose estrogen therapy is a hypercoagulable state, but not the progesterone therapy. Okay. That is about the question related to McConnell sign and the pulmonary embolism. Okay. Right. Next. Now, you see this particular chest X-ray. Which of the following is the diagnosis of this chest X-ray? Pneumonia, acute respiratory distress syndrome, lung abscess, bronchiectasis. Which of the following is the diagnosis of the following chest X-ray shown to you? Very good, Avinash. So the answer is B. The answer is B. So it is whiteout lung. Right? It is whiteout lungs. So in ARDS, which is nothing but acute respiratory distress syndrome, it is a clinical condition where you will have acute onset dyspnea. Right? There will be acute onset dyspnea. And the lungs which are affected is bilateral. The lungs which are affected is bilateral, and there will be presence of bilateral diffuse infiltrates. Right, bilateral diffuse infiltrates. Okay, that is what is your ARDS. That is what is your ARDS. The individual will have acute onset dyspnea, and the individual will have bilateral diffuse infiltrates will be there, and because of this bilateral diffuse infiltrates, there will be presence of a complete whiteout lung. Right, the entire lung is completely a whitewash. And ARDS, you should know the criteria. The name of the criteria for ARDS is what? That is Berlin's criteria. Right, the name of the criteria is the Berlin's criteria. The word A stands for acute in onset. Right, the word A is acute onset. The word R is reduced PaO2 by FiO2. Right, reduced PaO2 by FiO2. That is R. D stands for, right, D stands for diffuse changes in the chest X-ray. Right, diffuse bilateral infiltrates. Okay. S stands for Swan-Ganz catheter. Right, S stands for Swan-Ganz catheter showing normal pulmonary capillary wedge pressure. Right, showing normal pulmonary capillary wedge pressure. That is what is your criteria of ARDS. And this PaO2 by FiO2 is reduced to less than 300. PaO2 by FiO2 is reduced to less than 300. That is what is your Berlin's criteria. That is what is your ARDS. Acute in onset, reduced PaO2 by FiO2 less than 300, diffuse bilateral infiltrates, and Swan-Ganz catheter shows normal pulmonary capillary wedge pressure. Right, Vijay Bhargava, very good. So how much is the normal pulmonary capillary wedge pressure? Normal pulmonary capillary wedge pressure is around 6 to 12 millimeters of mercury. Right, it is around 6 to 12 millimeters of mercury. Okay, so that is about your Berlin's criteria. Okay, next. Now, if you take the question now, what are the other options which are given to you? Pneumonia, lung abscess, bronchiectasis. The options whichever are given to you, let me show you the respective chest X-rays. Let me show you the respective chest X-rays. Okay, you take the pneumonia. So in pneumonia you have the lobar consolidation. Right, now can anyone tell me which particular organism will cause right upper lobe consolidation? Any one of you, please. Which particular organism will cause right upper lobe consolidation? Which particular organism will cause right upper lobe consolidation? Any one of you, please. Klebsiella, very good, Samuel. Very good, Samuel Alamatu. Right upper lobe consolidation is seen in case of Klebsiella. Right, excellent. Okay, that is with the Klebsiella. Okay, right. Now, and you take Streptococcus. Streptococcus pneumonia, mainly it is the mid-zone or lower lobes are affected, whereas right upper lobe, it is your Klebsiella. And some of you are telling like Staphylococcus aureus. Staphylococcus aureus will not cause lobar pneumonia. Staphylococcus aureus will cause bronchopneumonia. And you have the patchy consolidation. You will not have lobar consolidation. Right? Next. Now you take the lung abscess. In case of lung abscess, that was the other option in our question. In lung abscess, you have a chest X-ray, right? You have an abscess in the center, right? And this is your a thick wall around the abscess, right? This is the presence of a thick wall around the abscess. Okay, so this is what is your lung abscess. It is not pneumatocoel. In pneumatocoel, you don't have the air and as well as fluid interface. But here, if you see, you have some black and white interface. You have that air bronchograms. You have that black and white interface is there within that particular abscess. But in case of the pneumatocoel, yes, was telling Vijay Bhargava. In pneumatocoel, you don't have that particular black and white interface. Everything will be completely black. Seen in case of Streptococcus pneumonia, right? Next. Yes, Soumya, I'm able to see your comments. What is that you have done? Yes, Soumya, I'm able to see your comments, okay? Right. Yeah. This is another interesting question. Clinical feature of this patient most commonly will be, clinical feature of this patient most commonly will be severe chest pain, palpitations, dyspnea, cough with expectoration. Yes, clinical features of this patient most commonly will be. Very good, Nirbhay Kumar. Excellent. Okay. What is the diagnosis? Yes, Avinash, why are you telling option B? Yes, Avinash, why are you telling it's palpitation? What is the diagnosis, Avinash? What is the diagnosis? Very good, Jinesh Jain. So this patient has S1, Q3, and T3 pattern. Where do you see that? You will see that in patients with the pulmonary embolism. So in pulmonary embolism, what is the most common symptom, Avinash? Most common symptom will be dyspnea, not the palpitations. Not the palpitations. But if the question is asked, what is the most common ECG finding? Right? If the question is asked, what is the most common ECG finding? Then you should answer it as the sinus tachycardia. So this is your sinus tachycardia. This is what is your sinus tachycardia. Okay. Yeah, that is the most common sign, right? Very good, Mohit. That is the most common sign. So the most common sign is the sinus tachycardia. And what are the other ECG features in patients with the pulmonary embolism? See, in patients with the pulmonary embolism, there will be increased afterload on the right ventricle, right? There will be increased afterload on the right ventricle. So thereby, these individuals, they will have what is called right heart strain pattern in the ECG, right? You see this. This is your right heart strain pattern in the ECG. What are those? Number one, right axis deviation. Number two, presence of right ventricular hypertrophy. Number three, presence of the strain pattern. What is that particular strain pattern? The strain pattern, it is nothing but asymmetric T wave inversions. Right? Asymmetric T wave inversions. Okay. That is what is your strain pattern. Okay. What is this asymmetric T wave inversion? Like this. This is your asymmetric T wave inversion. And symmetric T wave inversion means what? This is your symmetric T wave inversion. Symmetric T wave inversion is like this. And symmetric T wave inversion, you will have this in ischemia. In myocardial ischemia, you will have this symmetric T wave inversion. Right? So, in case of pulmonary embolism, there will be increased afterload on the right ventricle. and that will cause right heart strain pattern. And the individual will have right axis deviation, right ventricular hypertrophy, and right ventricular strain pattern. Okay, right. Yeah, even in very good, Rajkumar. Even in hypokalemia also, you can have flat T wave or T wave inversion can be there. Right. Next. Yes. What is this particular X-ray suggestive of? Hampton's hump, Pallas sign, Western mark sign, McConnell sign. Following X-ray is suggestive of. Right, very good, Madhusri Datta. The answer is Pallas sign. The answer is Pallas sign. So what is that you're observing here? You're observing the presence of enlarged or dilated or prominent, right, or prominent right descending pulmonary artery. And where do you have this Pallas sign? This particular Pallas sign is seen in patients with the pulmonary embolism. Yes, Shama, it is not 1, 2, 3 sign. 1, 2, 3 sign, you will see that in sarcoidosis. And in 1, 2, 3 sign, you will have right paratracheal lymphadenopathy, right and left hilar lymphadenopathy will be there in 1, 2, 3 sign. It is not that what you are observing in this particular X-ray. You are observing the presence of a prominent right descending pulmonary artery. That is what is nothing but your Pallas sign. And what is the investigation of choice in pulmonary embolism? We have discussed this point recently. What is the investigation of choice in pulmonary embolism? See, the investigation of choice in patients with the pulmonary embolism is CT pulmonary angiography. CT pulmonary angiography. That is what you will see in pulmonary embolism. Okay, right. Now, you take the other signs in the pulmonary embolism. The other signs in the pulmonary embolism is the presence of a wedge-shaped infarct. And this wedge-shaped infarct is nothing but Hampton's hump seen in pulmonary embolism. Okay. Yes, Vaibhav Ahuja. Gallium-67, we do that in sarcoidosis. Yes, Vaibhav. Gallium-67, we do that in sarcoidosis, but not in case of pulmonary embolism. All right. Next. Now, this is your Pallas sign, and this is your Western mark sign. So, what is Western mark sign? Western mark sign is pulmonary oligemia. Right? Western mark sign is pulmonary oligemia. Okay. That is, this is Western mark. So now chest X-ray, 3 signs: Western mark sign, Pallas sign, and the Hampton's hump. These 3 are the signs in pulmonary embolism. Answer this. Very interesting X-ray. Which of the following is the characteristic finding in this X-ray? Meniscus sign, deep sulcus sign, tram track sign, signet ring sign. Yes. Right. Very good, Samuel Alamotu and as well as Avinash. So this is nothing but your meniscus sign. This is nothing but your meniscus sign. So what is that you are observing actually? It is the presence of left-sided pleural effusion. Right? It is the presence of left-sided pleural effusion. Okay. And what is that you are seeing? You're also presence of the costophrenic angle blunting. Right? There will be also presence of the costophrenic angle blunting. Okay. Next. whatever the arrow you are seeing here, the yellow colored arrow, that is suggestive of the Ellis S-shaped curve. That is suggestive of Ellis S-shaped curve. That is suggestive of Ellis S-shaped curve. Now, this Ellis S-shaped curve, that is also called as the meniscus sign. That is also called meniscus sign. Now, you may ask, what is deep sulcus sign then? Where do you see deep sulcus sign? Any one of you? Yes, can anyone answer? Where do you have this deep sulcus sign? Why pleural effusion, Shashibhushan? You have that blunting of the costophrenic angle seen in pleural effusion. Yeah, in pleural effusion only you have that meniscus sign. Yes, Shashibhushan. In pleural effusion only you have that meniscus sign. Okay, right. And can anyone tell me, where do you have this deep sulcus sign? Yes, where do you have this deep sulcus sign? Deep sulcus sign, it is seen in patients with the very good Lokesh Kumar. Lokesh Kumar and Rizwan has answered it. Very good, excellent. And this is what is the deep sulcus sign. This is what is your deep sulcus sign. You can see that here on the right side. Okay. This is what is your deep sulcus sign. So what will happen in this deep sulcus sign? The air enters the pleural space by crossing any of its boundaries, such as chest wall, mediastinum, lung, or diaphragm. Air will enter into the pleural space by crossing any of its boundaries, either chest wall or mediastinum or lung or the diaphragm. That is what is called as the deep sulcus sign, seen in patients with the pneumothorax. Seen in patients with the pneumothorax. Next, you take the other two signs. Right. Now, please tell me, what is a condition where you will have tram track sign and where do you have signet ring sign? Yes, where do you have tram track sign and where do you have signet ring sign? Tram track sign, you will see that in patients with the bronchiectasis. You will see that in patients with the bronchiectasis. And where do you have this signet ring sign? Any one of you? Even the signet ring sign, it is also the HRCT finding in bronchiectasis. Right? Even your signet ring sign is also a HRCT finding in patients with the bronchiectasis. Okay? Right. Now, let me just show you the other signs. Right. So this is your tram track sign. This tram track sign is seen in patients with the bronchiectasis. That is what I have taught you now. Yeah. Yes. Answer this. What is the type of heart failure? Sorry. What is the type of respiratory failure you will see in this patient? Type 1 respiratory failure, type 2 respiratory failure, type 3 respiratory failure, type 4 respiratory failure. See, these are all like very important images correlating with the respiratory system knowledge. Yes, let me see how many of you can answer. Right. So, what is this diagnosis suggestive of? The diagnosis, it is suggestive of emphysema. Right? Diagnosis, it is suggestive of emphysema. And in emphysema, what type of respiratory failure you will have? You will have type 1 respiratory failure. Whereas you take other subtype of COPD, because emphysema, it comes under your COPD. Emphysema, it comes under your COPD. And the other subtype of COPD, that is the chronic bronchitis. That is your chronic bronchitis. So in chronic bronchitis, you will have type 2 respiratory failure. In chronic bronchitis, you have type 2 respiratory failure. And type 3 respiratory failure, that is perioperative respiratory failure. Type 4 respiratory failure, it occurs secondary to the hypovolemic shock. So that is about your the types of respiratory failure. That is about types of respiratory failure. Okay. And whatever the image which is shown to you is emphysema. And in emphysema, what is the type of respiratory failure? You will have type 1 respiratory failure. Okay. That is about the clinical scenario, right? So this particular session, I will wind up with this particular images. Actually, I should have discussed the pulmonary function tests, images related to pulmonary function test. Don't worry, I will be doing many more sessions on the image-based questions. And the sessions will be there every day at 10:30. And those students who did not watch the previous sessions, please watch them in a recorded format. That will be very much useful to you to crack your upcoming FMGE image-based questions exams. Okay, right. Now, yeah, tubular heart is seen. Very good, Raja. Now, why do you tell that it is emphysema? Right? Why do you right? Why do you think that it is emphysema? You have bilateral hyperlucent lung fields. You have bilateral hyperlucent lung fields. That is one thing. And the second thing is the presence of the tubular or vertical heart. And the third important thing is the presence of the low set diaphragm. The presence of the low set diaphragm. The diaphragm is compressed downwards. And yeah, and Mohit, type 4 respiratory failure, it is secondary to hypovolemic shock. Right? In case of the shock, the perfusion to the respiratory muscles will be reduced. When perfusion to the respiratory muscles is reduced, that is the point when the individual will develop type 4 respiratory failure. Okay. Yes, Mohit, is that clear? Right. So this finishes the image-based questions for today. And tomorrow I'll be there again live in front of you at 10:30 to discuss the image-based questions. Thank you very much. Good night, and follow all my image-based questions on the Arise Medical Academy platform. Thank you very much. Good night, and see you tomorrow.